Behavioral health, an overview of the current crisis and how to approach it. We all know that this is an underserved area, and the due focus that it needed for decades was not given, and we have a complex situation. So, in order to approach this, we have to understand that behavioral health is affected by multiple facets of the society, and all of these have to contribute to an improvement. Without all of them participating, whether we have a 2-year or 10-year or 30-year plan, we will not make a dent in the problematic system. All of them have a responsibility. If you look at time and intensity and complexity of illnesses and cost of treatments, they all have a relationship which we all understand very clearly. We need to treat early to reverse the illness and reduce costs. We have to look at various aspects of health and divide the problems into various categories so that we can match the appropriate systems taking care of them. So if you look at it, currently it's in our system, it's the emergency departments and med and surge inpatient units that are actually nowadays picking up more of the complex mental health problems. That's not ideal. These should be picked up at primary care clinics, schools and university health systems and employee health systems so that they can be detected and treated early. Looking at early detection and treatment versus late and low or high expense per patient, we can put together a graph in which we can show that there's roughly about 4 systems that are working. They're struggling, but at least working. These are high cost systems and these are relatively lower, and there's big gaps in between. Notice that if a patient arrives at a level which is right just above the one lower level, this patient's needs are going to be met by the EDs or the inpatient units. This is misuse of these systems. Too much resource for a problem that could have been handled here. Also, the insurance companies often decline payments, and the hospitals and inpatient units have to eat the costs because the insurance system says send them to a lower level of care, which unfortunately does not exist. But the insurance companies don't listen to that part. So we also have to look at another aspect, that it's the number of lives that these systems can touch. Something like this. Earlier, we can treat a lot more patients. These systems will have limited number of patients and very high costs. And if we treat them here early, it's likely that there'll be less progression in this direction. So if you do not attend to this area, but only build inpatient units and EDs, you actually are not reducing the flow of patients to these higher level centers, and it's actually going to be ineffective very quickly. So we need to look at what we don't have. We do not have a lot of things, and they all can be put in. Well, let me say this thing. We actually had them, but lack of payment, rigorous rules, which were inconsiderate of the restrictions and the limitations of the systems, just disintegrated them, and we lost all of these things. Many of them are not even paid. So we need to bring them back. All of this cannot be done by just healthcare professionals. The responsibility lies in many areas. Government and legislative bodies have a big role. There's a lot of stigma that comes and descends from top down that can be changed. Confidentiality laws are poorly implemented and sometimes come in the way of important critical information exchange. CFR 42's implementation is similar. Then there's other important things such as buprenorphine requiring waivers. This leads to reluctance of many hospital systems to engage in that, and a life-saving medication becomes a problem to be dispensed. There's stringent rules on IOPs. Insurance don't pay and decline treatments constantly, and also force patients to pay their deductibles up front. That's not helpful. Medicaid rates have not changed in years. Medicare doesn't even recognize licensed mental health counselors, so these educated professionals are lying waste. And then BH systems are held at a very high standard, but they're paid the lowest, and the risk of liability and corrective action is very high. It's better to go work in Dunkin' Donuts because you can clock off at the right time and you get paid about the same, but you don't incur those risks. Public offices have their responsibilities: housing, social supports, job opportunities, state fundings of complicated illnesses, school support systems, etc., need to be attended there. Healthcare professionals should not be sitting down filling out forms for Social Security disability, should not be looking for free medications available to the patients, and should not be working on IEPs and things like that. It's the job of public systems and school systems. Healthcare professionals have their own responsibilities. They need to attend to those. They need to take care of the patients, improve education, do research, enlarge evidence base, bring automations, and attend to provider burnout. Burnout is a complicated problem, and it should be called exploitation, because many hospital systems, for their business work and because the insurance systems who decide not to pay, kind of condoned by many public systems, lead to a situation where healthcare systems want the professionals to do 15 more things in the same 15 minutes. That leads to provider burnout, dissatisfaction, and most importantly, poor patient care. The patient and the physician both are not given a chance to actually deliver what they can. So all of these offices have their responsibilities, and without all of them contributing, it's not going to work. We have not enough behavioral health professionals anyway, and these situations are creating further problems for the ones that aspire to become professionals. Now, what can hospital systems do? They can focus on the areas of gaps. They can look at these yellow flags and start setting those up. But without the government, without the insurance systems, without the legislative bodies and public systems supporting them, it's just not going to work. So we need to understand that we all have a responsibility to do this thing. And if an academic medical center combines with a couple of hospitals, it can do a lot. Academic medical centers supplying evidence base, ultra-specialized specialist support, quality and education, whereas local hospitals can build spaces, staff them, and develop workflows and processes to support the patients. They can also network with local bodies and other professionals in the area so that they can work together to not duplicate, but actually complement each other. And then most importantly, these leaderships need to go and work with public offices and government, but mind it, a receptive public office and a receptive government, so that the guidance provided by these two can be effectively heard and implemented in the proper way to support the overall system. There is a lot of incentive and there's a lot of potential, and we need to exercise that by a cooperative effort with everybody holding their part of responsibility. Thank you.